the womb, she will naturally accept your plan of management. I will answer all your questions. These are the common questions that will come to you. But let me just finish this task so that we can take the questions. Okay, I'm not dismissing your concerns. So the GROW 2.0 is basically it's an electronic version of the gestation related optimal weight chart. So as I mentioned that we can use it for both. Okay, we can use it for even the fundal height. We can use it for the fundal weight, fundal height and fetal weight. So both can be used. Okay, here they have taken fetal weight. That is why you can see it in the form of circle here and they have been monitoring. Okay, it's very, very easy. So you can just look at how many weeks. Okay, and the growth is low here because it has fallen. Okay, and so she will be being monitored under serial growth scans. So this is what is the GROW 2.0 charts that you guys should be familiar with the lines and everything. Okay, it is available in the mobile app as well. So this is very much customized. They use the ethnic origin, height and weight, the pre-pregnancy weight, and even for the twin pregnancies, you can get to see the twin discordance as well. So it's very much some, it's easily used by the midwives in here. And even the patients also can log in through their own user ID and password. They can also see how the baby is growing. It will be shown in a simple diagrams over there. Okay, so this is again a normal GROW 2.0 charts that you should remember. This is 40 weeks. Okay, everything is normal. Okay, and this is only the fundal weight they are measuring. This is between the 50th percentile and 90th percentile. It is going properly. The growth trajectory seems to be fine in here. Okay, and this is one of another GROW 2.0 chart which I'm going to show here. Again, here also they are measuring the fundal height. Okay, I think it's missing. It has to be into. Okay, because this I have created on my own. So that's why some mistakes are there. Okay, this is into. Okay, and she's 36 weeks and growth is falling because it is almost touching the 10th percentile. So it is 60th percentile in here. Okay, so this is one more GROW 2.0 chart which I'm going to show in here is 37 weeks. Again, they have monitored the fundal height and it is falling in here. Okay, so you can go through it. Not only your not only the FGR, even the macrosomia also can be diagnosed with this, where it is more than 90th percentile persistently, more than 95th percentile persistently. Even the macrosomia babies also can be plotted in here. So now I will take the first question here. So she has got high risk factors, I told. If she is a low risk, no risk factors, okay, then we will only do the serial measurements of symphysia fundal height that the midwife will be doing. If it is less than 10th percentile, then they will be subjected to the biometry and the umbilical artery Doppler. So high risk factors, this is where maximum questions are coming. You guys have to pay attention here. One is that medical history. If she had any maternal medical conditions like chronic kidney disease, APLA, autoimmune conditions, that is where she comes under high risk, where you deal with this maternal medicine module, right? All those maternal medicine topics would require your serial growth scans because they're all high risk factors. Second is the obstetric history, especially the previous obstetric history. If any baby was diagnosed with previous history of FGR or a stillborn, or previously she had a hypertension in the previous pregnancy. Okay, all those also will come under eligible for the high risk factors and serial growth monitoring. Then they are asking these things. Papa less than 5th percentile itself is making her high risk factor. Echogenic bowel, presence of echogenic bowel, you get to see that in your antenatal care. Presence of echogenic bowel where you have to, that's a patient safety point that you have to advise her the serial growth scans. Okay, very, very, very important. Then any significant bleeding, and then single umbilical artery. These are the common things that they're testing you. Okay, Papa, echogenic bowel, and single umbilical artery. All these people, you should start aspirin for them, 150 milligrams, okay, less than 16 weeks. Then subject them to the uterine artery Doppler during a anomaly scan. So how you should remember is that in that we are checking two things. One is the uterine artery Doppler, because to recommend serial growth scans from what gestational age, I will make it simple for you guys. One, you have to look at the uterine artery Doppler and estimated fetal weight. If both are normal, that is, she's a high risk lady for sure, she requires a serial growth scans for sure, but her uterine artery Doppler is normal, And estimated fetal weight is also more than or equal to 10th centile. That means both the parameters are normal. Then from 32 weeks onwards, okay, from 32 weeks onwards, if any one is abnormal, be it uterine artery Doppler or estimated fetal weight is less than 10th centile, then you do it from 28 weeks. Forget about this 26. Okay, this is, I'm just trying to make you guys simplified because you're not giving part 2 to be very, very specific. Okay, so remember, if normal uterine artery Doppler and your estimated fetal weight is less than 10th centile, or your abnormal uterine artery Doppler but normal estimated fetal weight. How to remember it? Any one, either one is abnormal, then from 28 weeks onwards. Third thing, abnormal uterine Doppler is also there. Along with that, estimated fetal weight is also less than 10th centile. That means both are abnormal. Refer them to the fetal medicine specialist, because it's important to rule out some chromosomal abnormalities, any structural problems in the baby, or any, the torch infections in the baby that could be associated. Involve the fetal medicine specialist there. Okay, so three things that I want you guys to repeat before we move on to the next one. Any one of you? Quick.
So we look at two things, one uterine artery Doppler and one the expected fetal weight. So if both are normal, then we do serial scanning from 32 weeks. If either of them is abnormal, then we'll do serial scanning from 28 weeks.
Yes.
And if both are abnormal, we're going to refer them to the fetal medicine.
Perfect. Okay, understood everybody? All of you reply?
Yes, ma'am.
Yes.
Okay, perfect. So let's look at this particular one now. Here is where there is a contradictory statement from the guideline. If you read the guideline, nowhere it mentions from 32 weeks onwards, 32 and above, you should be doing the ductus venosus. If you read the recommendations, if you read the guideline in detail, it nowhere says that you need to do the ductus venosus from 32 weeks onwards. However, if you look at this picture, it says that between 32 to 33 plus 6, you can still do the ductus venosus. Okay, this is the confusion number one. Irrespective of it, irrespective of this, gray zone, any one is abnormal is enough for us to go and deliver the baby. Remember this. Or. We are giving so much of importance to your short-term variations there. Anytime on the computerized CTG, you see repeated unprovoked decelerations are there on the computerized CTG, enough for you to go and deliver the baby irrespective of the gestational age. Maternal indication like uncontrolled hypertension, significant proteinuria, she's almost in impending eclampsia and things like that. Yes, you're delivering her immediately. You're not looking at any of these. Okay, that becomes like a category 1 cesarean section for us for the maternal and fetal indication. If that is not there, then we look at these parameters. Depending upon the gestational age, ductus venosus, short-term variations, we look at it. But any one abnormality is enough for us to go and deliver the baby. Did I clarify the doubt here?
But he didn't specify that we should go for cesarean section if the short-term variation is low.
Yeah, I will come to that, dear. I'll explain that.
Make it absent and reversity, make it clear. Sorry for that.
No. Are you trying to say that, is it something I'm saying? Is it wrong?
No,
Is it?
no, not sure. No. But I am saying, like, he didn't clarify in the graph. Same that we done an absent and reverse it, that we should go for
So for that, you
cesarean
need
section.
to read the entire guideline. I have decoded it for you.
Why,
I will explain. So I'm trying to understand that, am I going anywhere,
You are
in a
very
wrong
good.
direction?
Thank you. No. But you clarify so many things, make it easier. Thank you.
Yes. Don't worry about it. I'll tell you what are the indications for the cesarean section. I have decoded that. I'll tell you. Okay. Understood now. Ductus venosus is generally not preferred 32 weeks and above. However, if they've done it because she was kind of under growth problem. She was under fetal medicine specialist for a long time. They have done the ductus venosus for some joy. It's okay. Look at the short-term variation. That is what is going to tell us. Look at the maternal, well-being. That is what is going to tell us. Ultimately, a computerized CTG is going to tell us something. If computerized CTG is also normal, your ductus venosus is also normal, there are no maternal indications for us to go and deliver. It's okay. It's okay. Okay? That's fine. You still have got time, like, you can continue up till 34 weeks and then deliver her. We are not letting her go beyond that if it is an early onset FGR. If it is a late onset FGR, then it's a different story altogether. I'll come to that. Just remember this point as of now. 32 weeks to 33 plus 6 weeks. You may do the ductus venosus, you may not. It's not going to decide anything. Your short-term variation less than 3.5 is enough for us to go and deliver the baby, and that has to be a cesarean section. Okay? Another thing I will tell you now. If the baby is less than 29 weeks, okay, I'm talking about all the early onset FGR, less than 29 weeks, okay? And then from 29 to upper limit of your early onset FGR, which is 31 plus 6 weeks. At any point of time, if you're following up, you see the absent or a reversed end diastolic flow in the umbilical artery. Okay. Then how do you monitor? You need to do twice weekly Doppler. This is one more recall that has come in the latest exam. They have given early onset FGR, mentioned it as absent end diastolic flow, reversed end diastolic flow in umbilical artery, Doppler. People told that we have to deliver. No. Your umbilical artery Doppler is not going to decide, even though the end diastolic flow is absent or reverse, is not going to decide the timing of the delivery. It is the ductus venosus or your short-term variation. So how they should be monitored? So the moment you see the early onset FGR who is diagnosed in less than 32 weeks, and you have subjected them to the umbilical artery Doppler, it is showing either absent or reversed, subject them to ductus venosus and computerized CTG. Involve the fetal medicine specialist. If everything is normal, call them back. Twice weekly computerized CTG and ductus venosus Doppler. Dr. Shruti, again, there is no weekly thing in here. Okay, the moment you see the Doppler changes, no weekly thing in here. It's always twice weekly follow-ups.
But that was
Clear?
only raised pulsatility index.
I'll come to it. As of now, just remember this, that once you see the Doppler abnormalities, then you, especially this absent end diastolic flow and reversed end diastolic flow, then you will monitor minimum twice weekly. So your question is pulsatility index of 95th centile. So you can do the weekly Doppler. That's your question, right?
Yes, yes.
Yes. So when the end diastolic flows are there, yes, you can do the weekly Doppler. But the moment you see the absent or reversed end diastolic flow, it is always weekly computerized CTG and ductus venosus. Your answer is justified because it was 95th centile, ductus venosus was present, but computerized CTG was also normal, then it makes sense. Yes?
That's my question. Why did we do a electronized CTG when there was no absent or reversed end diastolic flow?
Sorry, the computerized CTG. Computerized CTG is by default, dear. You cannot send her without doing a computerized CTG because that is what is telling us. It's important that both should be normal before we send her, because that is what is telling us whether the baby is in chronic hypoxia or not. Computerized CTG is the ultimate thing for us.
But otherwise, according to the guideline in that patient, because of umbilical artery PI, she should be subjected to only weekly Dopplers, right, ma'am?
Yes, but you need to have the computerized CTG done. If it is normal, then weekly Dopplers.
But is
You
it
have to get the go on.
Isn't the electronized CTG and the ductus venosus Doppler only to guide delivery?
Yeah, guide delivery, that's fine. But unless you do it, how do you know it's normal?
So we do it only when it's absent or reversed?
No. So you have the exact picture in here. The ductus venosus is present, Umbilical artery is 95th centile, but still the baby is having chronic hypoxia. Isn't it? So why do they have to give or and all? If one is enough, then you can do it. Why do we need to do the short-term variations? Got my point? Okay, forget about all of this, even in India for that matter. Do you do the NST or not before, even if everything is normal, the scan is normal, everything is normal, they have come with reduced fetal movements. Do you do the NST or not?
Yes, NST is done.
Yeah. So why do you do it? Scan is normal, blood flow is normal, end diastolic flow is present. Then why do you do the NSTs?
What is NST?
Non-stress test, which they do it in India. Yeah. Basically, it's the electronic monitoring.
But it's mean that every patient who is kept on monitoring, we have to do the Dopplers plus this short-term variability CTG.
Yes, that's by default we do it. Antenatal CTG, which is nothing but computerized CTG. We do it before we reassure them that whether they can come for the weekly Doppler, or we have to go and deliver them. That is something by default we do it. Okay, clear?
Ma'am, so let's say a station was where we get umbilical artery Doppler, which is showing pulsatility index more than 95th centile.
Can we answer in the form of a question? So I have got few questions and clarify it.
Yeah.
Oh, thank you. Please mute yourself and close your camera, please.
बच्चे नहीं गए शिरू उनको लाना था ना उनको लाना था ना
please take care of your mic, please. Okay. So I will take up this. I will take up this questions. Yes, go on.
Yes, doctor. Doctor, when to do the computerized CTG, even if the umbilical artery Doppler is normal, we have to go for a computerized CTG, or once it's diagnosed as FGR, we have to go for a computerized CTG.
See, irrespective of, say, for example, even if you have diagnosed something like umbilical artery, which is raised, the pulsatility index is raised, it is more than 95th centile, she has come to you. We always do the computerized CTG, make sure the baby is okay, and then only we tell her the safety netting and the follow-up Dopplers.
Okay, doctor. And
we do not discharge her to home. I mean, we do not send her home without having the computerized CTG, which is being attached to her.
Yes, doctor. My question is whether we should go for a computerized CTG if the umbilical artery Doppler is normal.
Umbilical artery Doppler is normal means what are you trying to say? It is a GA.
Yes, exactly.
Okay, so now I will ask you one more question. So define SGA and define the early onset FGR, late onset FGR. What is severe FGR? All of that.
Yeah, SGA is estimated fetal weight less than 10 centile with no Doppler abnormalities.
Mm-hmm.
And
okay. Less than 10 percentile, yes. And there is no Doppler abnormality. It's SGA.
Yeah.
Yes. Early onset FGR?
Early onset, if the onset of the FGR, if the estimated fetal weight is less than 10 third centile, or if it's less than 10
fetal weight
centile,
or abdominal circumference?
Less than third centile, or umbilical artery PI is more than 95th centile, or the uterine artery PI is more than 95th centile. We define it as
so basically,
FGR.
Doppler changes should be there along with the 10th less than 10th centile to call it as early onset FGR. Anybody who is less than 32 weeks, that means up to 31 plus 6 weeks will come under early onset FGR. Okay, and late onset FGR?
If the onset is after 32 weeks, from 32 weeks onwards, but again with the same criteria. But if the estimated fetal weight, if there is a fall by more than 50th centile, then also it's a criteria for the late onset FGR. Or if the CPR is less than
severe FGR?
Sorry, doctor?
Severe FGR?
Sorry?
Severe late onset FGR?
If the estimated fetal weight is less than third centile with Doppler abnormalities, we
no,
call it as
no,
severe.
No Doppler abnormalities. Need not to have
constant growth. Constant growth.
Enough. Third centile is enough for us to quote her as FGR there. You don't have to have any Doppler abnormalities at all. Okay. So SGA less than 10th centile, but no Doppler changes is SGA. FGR either estimated weight or abdominal circumference less than or equal to third centile or or less than 10th centile plus abnormal Doppler. So less than 3rd centile is enough for us to label it as fetal growth restricted baby. Okay? But less than 10th centile without Doppler changes is SGA. With Doppler changes, it is FGR. If that is being manifested before 32 weeks, then it is early onset, and more than or equal to 32 weeks, it's a late onset FGR. This much is clear. Now I will answer your question before I take up the, this thing. Whatsoever it is, if she comes to us from the midwife, she has been referred to the hospital, like be it a district or a tertiary hospital, like obstetric units. So, and even she's saying that my SGA is all okay and my baby is all okay. It's just that less than 10th centile, no Doppler changes, but we always do the computerized CTG quickly, meet the criteria, and then discharge her for the follow-up. Okay, that is something, it's like you remember it like your normal CTG, you do it back home. So we always do that if there is any concern, making sure that everything is okay and discharge her to the follow-up. So the first question to you guys. The midwife, she's a low risk woman. She's undergoing the tummy measurements, that is symphysia fundal height measurements. So that has started from 26 to 28 weeks onward. So every 3 weekly, she's undergoing the symphysia fundal height measurements with a midwife. And now the midwife has identified it as a slow or a static growth. Okay, slow or a static growth. So she has arranged for a biometry and a Doppler. And the fetus is now diagnosed with less than 10th centile, but normal Doppler. How will you monitor this pregnancy? This is one of the variation you can get in the exam.
Every 2 weeks, we'll do scan and Doppler.
Serial
Perfect.
monitoring since 28.
Why?
The one we discussed, ma'am, that if either of them is normal. Okay, that's for FGR.
See, that is also risk stratification from the early pregnancy. That is nothing related to this. That is high risk women. Okay, high risk women, we subject her to the uterine artery Doppler. If uterine artery is abnormal, normal, estimated fetal weight less than 10 centile, that is different here. This is the low risk category. Here, I'll show you this.
Okay,
See
yeah.
this one. Can you see this? This one. No risk factor. Anomaly scan, estimated fetal weight, everything was more than 10th centile, and we are doing the serial measurements for her. Okay. And now the symphysia fundal height is falling less than what it is supposed to be. So they have been subjected her to the growth scan and a Doppler. So now it has confirmed a case of small for gestational age, which is SGA, but no Doppler. No Doppler abnormalities. It's a clear cut case of SGA. So now how do you monitor her? This is irrespective of the gestational age I'm talking about.
Fortnightly growth and Doppler.
Perfect. Okay, it is 2 plus 2. Okay, I used to remember it as 2 plus 2, which is because we never do the fetal biometry less than 2 weeks. There's no point in doing the growth scan in less than 2 weeks, and you don't get to see any significant difference in the growth of the baby, hardly few grams. So before we used to do 3 weekly, but now it has been changed. So every 2 weekly, whatsoever it is, be it early onset FGR, late onset FGR, or a SGA, the biometry will always do 2 weekly. It's only the Doppler that changes. Okay, so it is 2 plus 2. That is 2 weekly. We do the biometry and the Doppler, which is fortnightly. Clear, everybody?
Clear.
Okay. So now the early onset FGR has been diagnosed. Say, for example, she's some 28, 29 weeks or something like that. Okay. And what surveillance would you arrange? And diastolic flow velocities, everything is present for her.
Weekly Doppler and fortnightly we'll do scan.
Perfect. Understood. It is 2 plus 1, which is 2 weekly biometry we do and weekly Doppler. Okay. 2 plus 2 for SGA and 2 plus 1 for your early onset FGR. Any doubt up till now?
No, clear.
Okay. Third, late onset FGR, she was diagnosed after 32 weeks, say for example, 33 or 34 weeks. Okay. So, and diastolic flow velocities are also present. So now what surveillance would you arrange for her?
Same.
Same.
Weekly Doppler, twice weekly scan.
Perfect. This is all you should remember. These 3 variations can come, and it's very, very simple. So always ultrasound biometry is every 2 weeks, which is fortnightly. Only the umbilical artery Doppler which changes. So it is always 2 + 2 here. And otherwise, in other cases, in both early or late onset, it is 2 + 1. Clear, everyone, up till now? Clear?
Clear.
Okay. Next question. SGA fetus. Okay. We diagnosed it as SGA fetus, less than 10th percentile. Somebody who was a low risk, identified on the scan, less than 10th percentile with normal Dopplers. We have been doing a fortnightly growth scans and Doppler for her. All investigations are normal. Okay, she's almost term now. All the investigations are normal. I mean, you kept monitoring, everything was normal. When will you deliver her, and what is the preferred mode of delivery?
38
39,
plus 6.
39 plus
38 plus 6.
One of you. Yes, Basma?
We will deliver her if we find absent intestolic flow or reverse it. Absent intestolic flow, it will be done.
No, let's not get confused in here. Everything is normal. Okay? Everything is normal. She has come to you at around 37, 36, 37 weeks. And she's saying, Doctor, everything is normal. When are you going to deliver?
We will take her till 39 weeks, 6 days.
Because
and
why
8
are you
days.
getting confused with a reversed absent end-diastolic? That then it will not be even SGA. No, SGA is only less than 10th percentile with no Doppler changes.
39 weeks. It will be normal.
39 weeks, 6 days.
Give me the window.
39 weeks, 6 days. By 39 weeks, 6 days. She
39,
should be delivered.
39 by
39
6
plus
days
6.
should be delivered.
Yes.
Not exceed.
39 to 39 plus 6 weeks is the window for the delivery for SGA babies who could be constitutionally small. She is less than 10th percentile. The Dopplers will be normal for her. Then only we call them as SGA. We'll never let them go till 39 weeks if they had a Doppler changes. Guys, don't get it confused. Okay, all investigations are normal means Dopplers are definitely normal. She remains to be a SGA till the end of her term. So we are going to deliver her by 39 plus 6. She is not supposed to cross that. So between 39 to 39 plus 6 weeks, we are going to deliver her. And the mode of delivery, please.
Can go for normal delivery.
Yeah, induction. Okay, induction of labor for her between 39 to 39 plus 6 weeks. Perfect. Next question. So this is what I have put here, that STA, the timing of delivery is 39 to 39 plus 6 weeks. Okay. The next question. A fetus has severe late onset FGR. Okay. That means less than 3rd centile. No Doppler changes, nothing. So again, she comes to you at around term. Okay. They have been monitoring. Everything is going fine. The baby is also less than 3rd centile only. But there are no Doppler changes, nothing. So when will you recommend her delivery? And what is the preferred mode of delivery?
6.
37 to 37 plus 6.
Okay, any other answer?
26 plus 36 plus 60.
So between 37 to 37 plus 6, whoever has told the first answer is exactly right. So the moment she's term, we are going to deliver her. The last gestational age which we have reserved, that is 39 to 39 plus 6 weeks, is only for your SGA without any Doppler changes. But if she is late FGR, less than 3rd centile, anytime between 37 to 37 plus 6 means when birth has to happen by 37 plus 6 weeks. Okay, this is late onset FGR, less than 3rd centile, no Doppler changes. Then only we are letting them cross the term gestation, which is 37 beyond. Clear, everybody?
So how it will be the mode of delivery?
Mode of delivery is also by induction of labor, and we prefer the mechanical methods over the pharmacological methods.
Okay.
Which is wholly. Okay.
In SGA, we
All right.
can give pharmacological methods of induction.
We can. There's no clear-cut, guideline on that. So you can definitely give, because there are no Doppler changes in there, and it's not like severely growth-restricted baby. So the pharmacological methods can be considered. Okay. Yeah. Early onset FGR is being monitored. Okay. Umbilical artery Doppler demonstrates. That means that the early onset FGR, once she was diagnosed, she was under the 2+1 monitoring, which is 2 weekly biometry and 1 weekly umbilical artery Doppler. And that 1 weekly umbilical artery Doppler now shows absent or reversed end diastolic flow. So what is your next step?
Delivery by cesarean section. If it is
Oh my
absent,
God, who is that? All
By
this while I have,
CDG and DV Doppler.
who is that? Basma.
I'm Basma.
All this while I told you guys that in early onset FGR, your umbilical artery will not decide the timing of delivery or anything for that matter. Who are the important parts?
Bi-weekly CTG and ductus venosa. Sorry.
Yes. Irrespective of the gestational age you're seeing there, be it 27 weeks, 28 weeks,
Once,
29 weeks,
but
up to
once you
31
reach,
plus 6 weeks.
yes,
It is
32.
twice weekly.
If it is
Twice weekly
reversed, it
computerized.
will be from
Twice
30 to
weekly ductal
32.
venosus and
Once she
computerized
reaches,
CTG.
Let's not confuse with all of that. Now she's less than 32 weeks. Let's not cross that. Okay, she's less than 32 weeks. Say, for example, she's somewhere around 29, 30 weeks. So now how do you monitor her? Absent or reversed end-diastolic flow is there. How do you monitor her? Twice
Twice
weekly. Yes,
CTG or ductus venosa.
Ductus venosus and CTG.
correct. Twice weekly Dopplers. Twice weekly computerized CTG or your ductus venosus is something that you're going to do. Okay, clear up till now? Next. Early onset FGR is under twice weekly surveillance with computerized CTG and the ductus Doppler. And now she has reached 32 weeks. Okay. The latest umbilical artery Doppler demonstrated reversed. That means that she must have had some absent end-diastolic flow before, and now she has reversed end-diastolic flow, but she has reached the 32 weeks now. Okay. Now what will you do? When would you
Cesarean
deliver?
section, but after corticosteroid. We'll give
See,
her
ductus venosus reports or
Yes, yes, it is
ECG
ductus venosus. 1 second. It is ductus venosus.
or STV.
Yes. Okay, who is asking to start the transcript? Okay, fine. So, early onset FGR lady, somewhere around 29, 30 weeks, she was diagnosed with an absent or reversed end-diastolic flow, but you have been monitoring her twice weekly, ductus venosus Dopplers and computerized CTG. Everything was going fine, 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 fine. Now she has come with, she has reached around 32 weeks, but now it is reversed. It was reversed before, or from absent, it has become reversed. She is 32 weeks now. When would you deliver, and what is the mode of delivery?
32 to deliver now.
Right coverage with cesarean section.
Cesarean section, but we'll cover her corticosteroid first.
Yeah.
Yeah, give all of that. Will you deliver her now?
Not cat 1. It will be cat 2, cat 3, but we'll admit her.
My question,
Blank
32
first.
weeks, will you deliver her or not? Category
Yes,
3 is
we will
not like
deliver
after
her.
1 week you will deliver, right? Will you deliver her today or not?
No, cover
We will
corticosteroid
deliver
within
her.
2 days, you should deliver her. But with
32
admission.
weeks you're supposed to deliver her. As simple as that. 32 weeks you're supposed to deliver her. As simple as that. Because it is reversed. Okay, I will just show you one diagram. Okay, see here. Whatever the gestational age in the early onset FGR, absent or reversed end-diastolic flow, you are monitoring her minimum twice weekly Doppler, which is ductus venosus Doppler and computerized CTG. Okay, everything was normal all this while, and then she reaches 32 weeks. If it is reversed end-diastolic flow, deliver them by 32 weeks. You can even consider early, but remember this one so that you will not get confused. 32 weeks is where you should deliver her. Same patient, okay, you were following her up. She has crossed 32 weeks also because it was still absent end-diastolic flow. The moment it is 34 weeks, you will deliver her. That means we are not letting any early onset FGR which was diagnosed before 32 weeks to cross 34 weeks for absent end-diastolic flow, and we are not letting the baby to cross 32 weeks for reversed end-diastolic flow when your ductus venosus, computerized CTG are normal. Clear, everyone?
Yes, but you mean that will be cat 1 cesarean section?
No, not necessarily. It's going to be a category 3 cesarean section. Plan her, admit her as you told, give her the corticosteroids, and then give her the, depending upon the gestation age, you give the magnesium sulfate as well and plan her delivery. in the form of cesarean section. Clear?
Clear.
You said that this ductus venosus and the short-term validity will be normal, then we will decide on the basis of umbilical artery in
Yeah,
early onset
exactly.
ST. Okay. Okay.
Exactly. So she has remained the same, but you cannot allow that early onset FGR who was diagnosed before 32 weeks to go until 37 weeks, right? The
Right.
baby will not
Right.
survive. So if it
Okay.
remains the same thing, like she was diagnosed to have absent, you continue to monitor her twice weekly. The moment she hits 34 weeks, deliver her. But from
Okay.
absent, it became reversed, or it was reversed all these while. Then you deliver her by 32 weeks. That's the earliest one. Okay? Clear?
Yes, ma'am. Yeah.
Okay.
Yes.
Okay, so we'll take up the next question. I think that was the question that I had. Absent and diastolic flow, we will deliver them by 32 weeks. Mode of delivery will be a cesarean section. And late onset FGR is diagnosed. Okay? Somewhere between 34 to 36 plus 6 weeks. And umbilical artery pulsatility index is more than 95th centile. That means your end diastolic velocities are present. And this is one recall question. So how would you monitor her?
By computerized CTG
Mm-hmm.
and umbilical artery pulsation, if it is raised, then we will deliver her by 36 plus 6 days.
36 to 36 plus 6 weeks. We are not letting any baby with a late onset FGR with 95th centile, okay, in the umbilical artery, we're not letting them to cross 36 plus 6. So anytime between 36 to 36 plus 6 weeks, we deliver them. But what is the monitoring until then?
Ductus venosus and ST.
No, ductus venosus, just
No
No,
ductus venosus.
it's
CG.
umbilical
Twice
artery
weekly.
MCA
weekly
PSA.
and
same 2-1 1-1
See
once
here.
week
it will be
So the
weekly.
umbilical artery Doppler is more than 95th centile. Here also
2-1.
monitor twice weekly computerized CTG. It's always twice weekly computerized CTG. If you're dealing with an early onset FGR, you will include the ductus venosus also. Okay. Otherwise, it is only the computerized CTG, but it is always twice weekly, guys. It's not weekly. The moment you
Yes, ma'am.
see the changes there in the umbilical artery Doppler, then it completely changes from weekly to twice weekly. Okay, so twice weekly.
Yes, ma'am.
If it is an early onset FGR, you include the ductus venosus. But if it is a late onset FGR, we don't include the ductus venosus. It only the computerized CTG, which is twice weekly. If it is less than 4.5 or absent end diastolic flow, in the late onset FGR, absent reversal of end diastolic flow is enough for us to deliver the baby. Or computerized CTG is showing short-term variation of less than 4.5, enough for us to go and deliver the baby. Only absent and reversed end diastolic flow in early onset, we are not delivering immediately. We are relying upon the ductus venosus and short-term variation. But in the late onset FGR, the moment you see absent end diastolic flow, reversed end diastolic flow, or the short-term variation is less than 4.5, which is enough for us to go and deliver the baby. If it is only the pulsatility index less than 95th centile, keep calling them twice weekly for the computerized CTG. And if it remains the same even up till 36 to 36 plus 6, induce them at 36 to 36 plus 6 weeks. This is the only, three indications where you do the induction of labor. Number one, late onset FGR between 36 to 36 plus 6 weeks. Umbilical artery Doppler is more than 95th centile. That means end diastolic velocities are present. Then induction of labor using mechanical methods. Late onset FGR, which is less than third centile, no Doppler changes. Then you deliver by induction of labor between 37 to 37 plus 6 weeks. SGA without any Doppler changes, induction of labor between 39 to 39 plus 6 weeks. The moment you see absent end diastolic flow, reversed end diastolic flow, ductus venosus is abnormal in the form of A wave is absent, or it is below the baseline, or it is reversed, or your computerized CTG is abnormal in the form of short-term variation is less than whatsoever the gestational age cutoff is there. In all these cases, irrespective of early or late onset, it is the cesarean section. Clear, everyone, on this?
Yes,
Yes,
clear.
ma'am.
So I will show one more slide for you guys so that you can just take the screenshot of it and remember it. Okay, so look at this. This is all you need. The mode of delivery in early and late onset FGR. Severe FGR is abnormal computerized CTG changes like abnormal short-term variation, or you have a spontaneous, repeated, unprovoked decelerations are there. Ductus venosus changes are given. Umbilical artery is showing absent or reversed end-diastolic flow. Then it is a planned cesarean section. If it is a late onset FGR, like less than third centile, okay, and SGA with normal umbilical artery Doppler, then offer induction of labor. Even late onset FGR, forget about this SGA, umbilical artery Doppler is more than 95th centile, but end diastolic flow is still present, then offer induction of labor. Clear? Clear, everybody?
Yes, ma'am.
So late onset FGR is basically third centile here. I think there is some clarity is missing in here. SGR with normal Doppler or late onset FGR. Yeah, this is the perfect one. Yeah. Can you see now? I'll just repeat this for you guys. So if you see absent end diastolic flow, reversed end diastolic flow in your umbilical artery, that means there are end diastolic flows are not there, absent. And abnormal computerized CTG or abnormal short-term variation, ductus venosus changes are there, then deliver them by planned cesarean section. Otherwise, you can induce them, be it late onset FGR, like less than third centile between 37 to 37 plus 6, or SGA with a normal Doppler, that is between 39 to 39 plus 6, go for induction of labor. If it is a late onset FGR, who's coming somewhere between 36 to 36 plus 6, your umbilical artery Doppler is 95th centile, but end diastolic flow is present. That means there is no absent or reverse flow for induction of labor. So in these cases, we generally prefer the mechanical methods of induction, that is Foley's. Any question from anyone? Clear? Everyone, is it too overwhelming? No one wants to talk.
Clear.
Give me a
Clear.
break.
Ma'am,
Give me a
clear.
break. Give me a break. Please talk. Okay, so this is in a nutshell, guys. In an early onset FGR, where we have been monitoring the early onset FGR using 2+1 formula, which is 2 weekly growth scan and weekly umbilical artery Doppler. The moment we see there is an absent or reversed end diastolic flow, they will come under close monitoring. That close monitoring would include twice weekly. So from weekly, it becomes twice weekly monitoring. And we no longer more interested in the umbilical artery Doppler. We are more interested in computerized CTG and ductus venosus that is guiding us about the timing of delivery. So remember, forget about this 25 plus 6 weeks and all, it's too early, baby. Remember it as like less than 29 weeks. Okay. Or is it 29 to 31 plus 6? That is upper limit of your early onset FGR. So wherever you see any one of the following is enough for you to deliver the baby. It could be spontaneous, repeated, persistent deceleration. This is common to any of the gestation for that matter. Ductus venosus is also common to these things, which is absent A wave or it is less than baseline. Only thing which you guys have to remember, which is in the exam they're repeatedly asking, is that if it is less than 29 weeks, then it is 2.6 is the cutoff. If it is 29 to 31 plus 6 weeks, then it is 3 is the cutoff. Okay, forget about this. I don't know why it has come in here. So it is 2.6 and 3 is what you have to remember. Give them the steroids and magnesium sulfate and deliver. Between 32 to 33 plus 6 weeks, we are more interested in the computerized CTG, less than 3.5, deliver them. The exact case we had today. That is enough. It is all or. We are not interested in ductus venosus. So computerized CTG short-term variation less than 3.5, deliver them, or abnormal umbilical artery Doppler like you have seen absent or reversed and diastolic flow, that is also enough for us to go and deliver. But that particular patient had a 95th centile, and diastolic velocities were present, but short-term variation was 3.2. So that itself was an indication for cesarean section. After 34 weeks, that is between 34 to 36 plus 6 weeks, it should be less than 4.5 to go and deliver them, or absent or reversed and diastolic flow is enough because it's a late onset FGR. 36 to 36 plus 6 weeks, this is one more recall. So the patient was 36 weeks. And so she came with this abnormal umbilical artery Doppler of 95th centile. So she was asking that when I can go and deliver. So you tell her that if we do the computerized CTG today, if computerized CTG is normal, then we call you back twice weekly computerized CTG. But she's already 36 weeks. So we don't have that much of window for her. So call her back in 2 to 3 days, get the computerized CTG done for her. Okay. And then you have to plan her delivery before 36 plus 6 weeks. So in this week itself, she has to deliver. Okay. That is one question that you have to practice. But any gestation for that matter, repeated provoked deceleration,
Need
there is a
admission.
medical indication you have to deliver. Yes.
Our case, she will need admission.
In that case, she doesn't require admission. Get the computerized CTG done for her. If it is normal, get the the preeclampsia profile done for her, blood pressure done, urine protein done, computerized CTG done. If everything is normal, you can send her home with a safety netting and call her back in 2 to 3 days of time for the computerized CTG. Okay. And then obviously we'll do the umbilical artery Doppler also to make sure that end-diastolic velocities are not absent. If everything is normal, then you have to give her the date before 36 plus 6 weeks for induction.
But our case, she was complaining of reduced fetal movement and the small
Not this.
baby.
No. In this patient, she didn't have any problem that. Okay. That's one of the recall.
Okay.
So,
This is another
yeah.
record. Okay.
Yeah. Okay, so this is all we have discussed today. So remember, the umbilical artery Doppler is the primary tool for monitoring in the late onset FGR to decide the timing of birth, but not in the early onset FGR. So the primary tool will be your computerized CTG, maternal well-being, okay, and all this middle cerebral artery and cerebral placental ratio. I know you guys have been using it on a day-to-day practice in Asian regions, but here MCA and CPR we don't do it before 37 weeks. Before 37 weeks, we are only interested in your umbilical artery Doppler and computerized CTG. It is not useful before 37 weeks. Maybe after 37 weeks, you can consider it to identify the brain sparing. And ductus venosus Doppler has no role in the late onset FGR. Okay, clear so far? Okay. So same thing, mode of birth, FGR with abnormal computerized CTG, ductus venosus abnormality, umbilical artery showing absent or reversed, go for cesarean section. Late onset FGR, which is like less than third centile, okay, and or the this one SGA with no Doppler changes, induction of labor. Just the raised umbilical artery Doppler in the late onset FGR, you can still go for induction of labor. Method of induction in SGA or FGR, mechanical methods are generally preferred, but you can still, for the SGA, you can still consider doing the pharmacological methods. Yes. So always you have to counsel her that even if you are dealing with somebody whom you can say the induction of labor is something that we can consider, as somebody told in the beginning itself that always the baby will have a less reserve, less blood supply, may not be able to cope well during the with the stress of labor, and a baby will be at a higher risk of requiring a cesarean section. That also point that has to be told to her. It's very, very important because these babies do not cope well. And another important updates in all the cases of FGR, you guys should not miss as far as your applied clinical knowledge is concerned, is that histopathological examination of the placenta should be considered in all the women diagnosed with a FGR. It will guide us in a way that basically it confirms the FGR. If it might confirm some many blood clots were there within the uterine vessels, and it can also confirm some ischemia, inflammation. If it is some infection, maybe the placenta may be small. So basically, it gives us so much of idea. So that is the reason that they are doing the histopathological examination of the placenta for all the babies. This you have to tell her. Okay. Second thing is that consideration has been given to screening for acquired thrombophilia for all the women diagnosed with FGR. Okay, these are the two things that you should not forget for your applied clinical knowledge points are concerned, that histopathological examination and screening for acquired thrombophilias is not now, 6 weeks after the delivery. If that comes positive, then we have to repeat it after 12 weeks. If that's also positive, then aspirin, low molecular weight heparin from the next pregnancy. And smoking cessation, they have given more importance there. And aspirin in the future pregnancy, they have given more importance. And serial growth scans, they have given more importance. I think this has remained the same from the previous guideline as well. But acquired thrombophilia, histopathological examination placenta, you guys have to remember. Okay, so you have to cover the future pregnancy also. This condition can come back. Okay, so booking in a consultant-led care unit, no more midwifery unit, consultant-led care unit, serial growth scans, starting aspirin, following up with this acquired thermophilia testing, and following up with that histopathological examination.